Hi, everyone. Welcome. I'm going to wait just a minute for everyone to join before I introduce our next speaker. Okay, I think we can go ahead and get started. Welcome back, everyone. I hope you've enjoyed the wonderful talk so far this morning. So I'd like to remind everyone to please use the Q&A feature for questions. You'll have an opportunity to have your questions answered at the end of this session. So I'd like to welcome you to our next session with our wonderful speaker, Dr. Raja Mehanna, who will be providing us with a thorough overview of what is new and what is ahead in Parkinson's disease treatment. Dr. Raja Mehanna graduated at the top of his class in medical school. He completed his neurology residency at Baylor College of Medicine in Houston, Texas, and then completed a fellowship in movement disorders also at Baylor College of Medicine. He completed another fellowship in movement disorders with an emphasis on deep brain stimulation at the Cleveland Clinic Foundation in Cleveland, Ohio. Dr. Mehanna is an associate professor of neurology at the University of Texas Health Science Center at Houston, McGovern Medical School. He is one of my colleagues, and we're thrilled that he is part of our group. He also at UT Houston, he serves as the director of the movement disorders curriculum for our fellows and residents, and he serves as the assistant director of the movement disorder fellowship program. Dr. Mehanna has received numerous awards and has been invited to talk nationally and internationally. He's authored more than 70 publications and has been a featured speaker at the HAPS Summer Lecture Series. We're so happy to have you here with us today. Thank you and welcome, Dr. Mehanna.
Thank you very much, Dr. Fersen, for this very kind introduction. So I know I am what is standing between you and lunch, so I'm gonna make sure to end on time. So I've been asked to talk about what's new and what's coming soon in the treatment of Parkinson's disease. So, as the title says, this talk will have two parts. In the part one, what's new, I just give a kind of an artificial boundary of going back to January 2019, kind of the last 3 years, since I gave kind of a similar talk in 2018. And what's coming soon will be further divided as well once we get there. So we have three new medication approved by the FDA since 2019, and I put them by chronological order: NOURIANZ, ONGENTYS, KYNMOBI, and GOCOVRI. So GOCOVRI was approved prior to January 2019, but got another approval, like for a new indication, by the FDA in 2021, and this is why I included it in this talk. So NOURIANZ, or estradiol, was approved in August of 2019. It is an adjunct to carbidopa-levodopa for patients with Parkinson's disease who have OFF episodes. So as I'm sure everyone on this talk is familiar, the OFF episodes are when your symptoms of Parkinson's disease recur despite you taking your medication, either because it takes some time for the medication to kick in, or it wears off before the next dose, or the drug simply doesn't kick in well, or not at all, what you call a dropped dose. So NOURIANZ was approved as an adjunct for patients experiencing these types of events. Now, NOURIANZ is an adenosine A2A receptor antagonist, which is kind of the first in its class of medication for Parkinson's disease. So far, everything has been focused on dopamine, a little bit also on glutamate, but this is the first time we have something acting on those receptors, which makes it interesting. What does adenosine have to do with Parkinson? On the left side of your screen, you see two images, two scans of the brain, PET scans of the brain. The normal patient is on top and the patient with Parkinson's disease is on the bottom. And you see there is an increase in the activity of the alpha-2A receptors in Parkinson's disease. And a way to look at it would be dopamine. When you give a patient dopamine, the dopamine presses on the gas to move the car forward. The problem is adenosine, which is hyperactive, as you can see on the scan on the left in PD, is like pressing on the brake. When you give an adenosine blockers, so adenosine antagonist, well, what you would do is you would be releasing the foot from the brake. So Parkinson's disease is because we don't have enough dopamine, so we don't press enough on the gas, but also because we have too much adenosine, we're pressing too much on the brake. A treatment would be to not just simply press on the gas further with dopamine, but also to release the brake with adenosine, for example. Now, NOURIANZ has been studied in 4 different studies, 2 in the US and 2 in Japan, and studied at different doses of 20 and 40 milligrams a day. Overall, it decreased off time by 1 hour to 1.5 hours a day, whilst placebo decreased it by 25%, by 25 minutes to 40 minutes a day. So if you, in addition to placebo, so further than placebo, NOURIANZ decreased off time by 45 minutes to an hour. Now, when you decrease off time, you also want to make sure that you're not causing more dyskinesia, which is kind of, tipping the balance too far. So we look at the on time without troublesome dyskinesia. And this is where the patient would be, has good control of Parkinson, does not have the dyskinesia, those wobbly dancing movement, or if those are present, they're not troublesome. And compared to placebo, NOURIANZ increased this on time without troublesome dyskinesia by roughly 40 minutes a day. In terms of side effects, so here you see placebo, NOURIANZ 20 milligrams, and NOURIANZ 40 milligrams. Dyskinesia was the most frequent, 8% with placebo, 15 and 17% with NOURIANZ, and more with the higher dose. All the other side effects are essentially in the single digit and seen more with the higher dose of NOURIANZ, such as dizziness, constipation, nausea, hallucination, insomnia, impulsive behavior such as gambling or sexual urges or impulsive shopping was only seen in 1 patient with the higher dose, 0.3%. Now, what's important when you consider the side effect of medication is how many patients had to stop the medication because of these side effects. Because you might have some side effects that are mild and the benefit is still significant. And so it's always about weighing risks and benefits, or benefits and side effects. And only 1% of patients with a lower dose of NOURIANZ had to stop the medication because of side effect, and 1% also with the higher dose of NOURIANZ. In terms of stopping because of hallucinations, no patient had to stop it because of hallucination with a lower dose, 1% with the higher dose, so roughly 3 patients in the whole studies. So in practice, NOURIANZ comes in doses of 20 or 40 milligrams. It's 1 tablet a day, with or without food. So that's a plus compared, for example, to carbidopa levodopa, when we tell you, oh, you have to take it half an hour before the meal or 2 hours after a meal rich in protein. This does not affect NOURIANZ. With or without food, any time of the day, morning or evening, doesn't matter. Most patients will only need the 20 milligrams. Now, of course, your doctor might decide, 20 is not enough for you, let's go up to 40. Or your doctor might decide to start directly at 40. Titration is not necessary. Personally, I prefer doing 20 to start with because, at least in the study, it worked quite well without too much side effects. However, if you need more, definitely you can go to 40. And if you're a smoker, if you smoke more than 1 pack of cigarette a day, then you need to start with 40 because the tobacco product is going to break down NOURIANZ in your system. Also, if you have moderate hepatic liver failure, then you should use 20 milligrams. If it's mild, you don't have to worry about it. If it's severe, you should not be on the medication. So that's NOURIANZ once a day, approved in the last 3 years for off time. Another drug is Ongentys or opicapone, which is also a once a day medication, also approved as an adjunct to carbidopa levodopa in patients with Parkinson's disease with off time. Now, it's not a new molecule in a sense. It's not a new family of molecules. It's still a COMT inhibitor, such as entacapone or Stalevo. It was studied in 2 different trials, comparing the 50 milligrams to the sugar pill placebo at 14 weeks. And in the first study, in both studies, really, it decreased the off time by like 2 hours, when placebo decreased the off time by like 1 hour per day. So overall, it seems that it decreases the off time by roughly 1 hour per day compared to placebo. Now, there was one study when they compared it to entacapone, 200 milligrams, which is what you have in Stalevo. Now, you might know that entacapone, you take it with every dose of carbidopa levodopa, whereas Ongentys will take it just once a day. And compared to entacapone with every dose of carbidopa levodopa, the opicapone 50 milligrams decreased off time by roughly an hour, so 60 minutes more than placebo, whereas entacapone decreased it by 40 minutes more than placebo. However, we cannot conclude that opicapone is better than entacapone, because the way the study was designed was to look if opicapone was worse. It was what you call a non-inferiority study. So what they designed the study was, is opicapone worse than entacapone? And the answer is no, but you cannot say it's better. Now, the advantage, of course, would be, to take it once a day. In terms of side effects, like all medication that treat off time so far, the concern is, of course, causing dyskinesia. And here you can see on the right side of the right column, 20% of dyskinesia versus 6% for placebo. All the other side effects are in the single digits. So dizziness, constipation, dry mouth, hallucination, insomnia, bit of loss of weight, syncope, and hypertension. Impulsive compulsive disorder only seen in 3%, in 3 patients, so 1.1% of the patients. No real side effect, psychiatric side effect in terms of anxiety or depression. So fairly well tolerated, not unexpected to cause a bit more dyskinesia. We know that this is a potential side effect of all drugs that we use so far to treat off times. Now, in terms of discontinuation, because that's what's important, as we mentioned before, 8% of the patient on Ongentys had to stop the medication because of side effects versus 6% on placebo. So still single digits and very close to placebo. So fairly well tolerated medication. Most frequent side effect being dyskinesia. So 3%, most side effect causing stopping the medication was dyskinesia, with 3% of patients taking Ongentys having to stop because of the dyskinesia, and 0.4% in those taking the placebo. So Ongentys is 50 milligram, it's once a day. Now, I had said that NOURIANZ was any time of the day with or without food. Now, for Ongentys, it's important to take it at bedtime and to not take any food an hour before or an hour after. Now, if you just take it before going to bedtime, you shouldn't really worry about not eating anything after an hour, but you should make sure not to eat anything an hour before. If you take it with food, it's really gonna decrease the absorption. If, like NOURIANZ, if you have some moderate liver failure, you should have the dose will be 25 milligrams. The third medication that was recently, on the last 3 years, approved by the FDA is KYNMOBI, or apomorphine sublingual. Now, this one is unique because it's of the route of administration. It's the only medication we have so far for Parkinson that is a film that, as you can see, a film that you put under the tongue to dissolve it. It's also, well, different from the other 2 we discussed. It's not unique. We do have another drug like that, but it's different than the other 2 we saw by the fact that it is used as needed when you go off, because it kicks in quickly, but it doesn't last very long. The other one we have as needed is inhaled levodopa in Brija, but that was approved before 2019. So I talked about it before. I'm not going to talk about it today again. So just for you to understand how to use it, I'm just going to go through the one slide on how the trial was made. So the patient had to be off, so completely off carbidopa levodopa, and then started putting the film under the tongue. They started at 10 milligram. If it didn't work, they went to 15. If it didn't work, to 20, then 25, 30, and 35 milligrams in the study. When would you say that the medication is working? Well, if it gave the patient the full benefit of their regular dose of carbidopa levodopa within 45 minutes. And once we found the right dose for the patient, then the patient was randomized to either getting a placebo, so a sugar film, or the actual drug itself. And when you look at the slide, so the y-axis is the change in the MDS-UPDRS, which is the motor scale that we use for Parkinson's disease, and the x-axis, the horizontal axis, is the minutes after putting the film under the tongue. The placebo is those black dots, whereas the KYNMOBI are those square, those green, blue, turquoise squares. And you see at 30 minutes that already the placebo film had decreased, so improved the motor symptoms by 3.5 points versus 11 points with KYNMOBI. That's 3 times. And you see at 60 minutes, it's at 2.3 points for the placebo versus 15 points for the KYNMOBI. So it's like a 7 times more improvement in these symptoms. So it's not about the amount of time off, it's actually about symptom control of the Parkinson, motor symptoms improvement. In terms of side effects, 28% of the patient experienced nausea. Now, this is not unusual. KYNMOBI is apomorphine. Apomorphine has been available for a very long time as an injectable. Some of you might have been exposed to it. So we know nausea is a side effect of apomorphine. Now, what is a bit unique to KYNMOBI, because of its mode of administration, being a film under the tongue, is the mouth and throat side effects. As you can see here, mouth or throat soft tissue swelling, 15%, or soft tissue pain and numbness and tingling, 13%, ulceration and inflammation, 7%, and redness without any of the above, 7%. In the KYNMOBI arm, all of these being more frequent than in placebo. Another side effect to note is also, well, dry mouth and sleepiness, 13% in KYNMOBI versus 2% of placebo. All the other side effects were essentially in the single digits. The discontinuation rates, how many patients had to stop the drug because of side effects, 28% versus 7% in placebo. So a bit more discontinuation rate than the other two we saw, but also a kind of unique indication. Now, 28% discontinuation rate still mean that 72% of the patient on this drug kept taking it, either because there was no side effect, or the side effects were minimal compared to the benefit that they derived from the medication. Those discontinuation were more in the maintenance phase, meaning the patient were titrated like in the study, 10 didn't give anything, 15, 20, 25, and we're going to go through the titration schedule in a minute. But you might not feel any side effects early on. It might be once you are taking the regular, your maintenance dose later on. A most frequent side effect leading to stopping the medication were the mouth and throat side effect, as well as the nausea and the vomiting. So let's talk about the nausea, since it's 28%, it's the most frequent side effect. Initially, it was recommended that patient taking KYNMOBI should start Tigan or trimethylbenzamide, which is an anti-vomit medication, 300 milligrams 3 times a day, starting 3 days before the first dose of KYNMOBI. And then, wean off from it once you don't need it anymore, usually in the first 2 months. Needless to say, this was kind of a heavy burden, because I mean, if I'm going to prescribe you something to take as needed, when you need it, if you need it, and then for that you have to take a medication 3 times a day to prevent nausea, that doesn't sound very as needed and really useful. In a sense, it's a burden. However, there have been more recent data, after marketing and commercializing this product, that you don't need to pre-medicate anymore, because if you're going to have nausea, then you can take it and it will take care of your nausea. And if you're not going to have nausea, you're not going to have nausea. It seems that pre-medicating it did not decrease the rate of nausea. So at this point, we don't need to pre-medicate. We have Tigan. If it causes nausea, then you can take it. So in case you heard this before, you have to take 3 times a day, 3 days before starting the KYNMOBI, that's not up to date anymore. It's not accurate anymore. Now, if Tigan is not available because shortages happen, then you want to choose Phenergan. But you should not use Zofran or other anti-vomiting medication that contains serotonin, because it can interact with KYNMOBI and cause a severe drop in blood pressure and syncope. So how is the titration? The titration will be done with a nurse. It could be in person at your house, or it can be virtual, whichever you prefer. A few rule of thumb, you will try the smallest dose and see if it kicks in. Kicks in meaning you feel completely on, like your carbidopa, levodopa would, within 45 minutes. However, if you do not kick on, you'll have to wait until the next off period, meaning you have to take a carbidopa and we're off again. and at least 2 hours before you try the next dose. So my rule of thumb, the way I do it is like I tell you, okay, we're going to do titration. It's going to be, Monday to Friday of next week. Let's set a time with the nurse, 7:30, 8 a.m., whatever it is, before your first of the day. And then the nurse will connect with you or visit with you and will give you the 10 milligram. And then, hey, you kicked in, that's great. We prescribe the 10 milligram and we leave it at that. Oh, it didn't kick in, that's fine. We'll do it the next day. Tuesday, we'll try 15, Wednesday, 20, Thursday, 25, and Friday, 30. And then we will stop wherever it works for you. We don't need to continue. And if 30 doesn't help, then we will not prescribe it, obviously. Once you find the right dose for you, you can use it up to 5 times a day, not more than that. And usually not less than 2 hours apart, and not twice for the same off episodes, meaning you'll have, okay, it didn't kick in this time, then we'll have to take carbidopa. And then, if when we have the next off, we can use it if need be. In terms of side effect, as I said, nausea, vomiting is the most frequent, but you have Tigan and seems to be quite efficient. For the mouth side effects, if you were to develop mouth side effect, you should stop the medication and do not try it again, because it seems it comes back with a vengeance. So quite a very good drug. In a sense, it's quite useful as needed, kicks in very quickly. It has 5 different doses versus Imbrija. It's great. You don't have to worry about the mouth, but you have only 1 dose. This one you have 5 doses, but you have, potential side effect in the mouth. So of course, you always have to go back to your healthcare provider who knows your specific circumstances to decide which one will be better for you. And finally, in the part of what is new, GOCOVRI. GOCOVRI, it's amantadine extended release. As I said, it was approved for dyskinesia back in August of 2017, but the FDA approved it for off episodes recently in February of 2021. And that's unique in a sense. It's the only drug so far that was approved for both off and dyskinesia in patients with Parkinson's disease. So basically, we saw that, in Ongentys, for example, and in NOURIANZ, which the two discussed today already, that these can increase dyskinesia. This dyskinesia is a frequent side effect. Well, not with GOCOVRI, because it was initially approved for dyskinesia, and then it showed, wow, it's actually very good for off time as well. So that's the only drug we have for off dyskinesia, for off time and dyskinesia. But of course, it has its own set of side effects, so it doesn't mean that it's the best drug for everyone. So I'm not going to present the data for dyskinesia, obviously, just for off time. In 2 different studies, you'll see here the difference between placebo and NOURIANZ is roughly 1 hour. So in the first study on the top right, patients on placebo had an increase in their off time by 0.3 hours at 12 weeks after starting the drug, whereas patients on GOCOVRI, the green line, had a decrease in their off time by 0.6 hours. So the difference was roughly 0.9 hours. And the other study, patients on the bottom left, patients on the patient on the placebo had an increase, this is the gray line, of their off time by 0.6 hours, whereas patient with on the GOCOVRI had a decrease by 0.5 hours. So you see that it's roughly 1 hour of less off time compared to placebo at 12 weeks. In terms of on time without troublesome dyskinesia, a marked increase with GOCOVRI in the first study on the top right, 3.6 hours in green versus 0.8 hours for placebo. And the bottom left study in green, 4 hours of more on time without troublesome dyskinesia versus 2.1 with placebo. So roughly 2 to 2.8 hours, between 2 and 2.8 hours of more on time without troublesome dyskinesia compared to placebo. Just taking a look at the pies here, because it's, as I said, unique to have one medication decreasing both the off time and the dyskinesia. The top row is the GOCOVRI, the lower row is the placebo, and you have the first study on the left and the second study on the right. The green is where we want you to be, the on time without troublesome dyskinesia. The yellow is the troublesome dyskinesia, and the gray is the time in off. And you see in both studies that the green part increased quite a bit, whereas the yellow part decreased quite a bit. So the dyskinesia time decreased quite a bit, and the off time decreased as well. So study 1, you went from 8.3 hours of on time without troublesome dyskinesia to 12 hours of on time without troublesome dyskinesia, with dyskinesia decreasing from 4.7 hours to 1.4 hours a day, and off time decreasing also a bit from 3.2 to 2.6 hours. Similar results with the study on the right. more decrease in the dyskinesia and some decrease in the off time versus with very good increase in the on time without troublesome dyskinesia. Whereas you get the placebo on the bottom, you will see some decrease in the troublesome dyskinesia, but not in the off time. And you do have some increase in the on time without troublesome dyskinesia. Now let's talk about safety, right? Because no medication is devoid of side effects. The most frequent side effects here is hallucination, seen in 21% overall of patients with on GOCOVRI versus 3% on placebo. Other side effects that we saw, and that and none of these was unexpected, because we have used amantadine, regular amantadine, immediate release, since the 1960s. So we know the side effect of amantadine. GOCOVRI is unique in its sense; it's once a day, and it was shown to decrease off time. So the side effects, nothing surprising to us, but need to be aware of it. Dizziness, 16%, dry mouth, 16%, constipation, 13%, leg swelling, 16%. Livido reticalis, which is discoloration of the legs, purple discoloration, 6%, fall, 13%, and drop in blood pressure, 13%. So quite a few side effects in the double digits. The most frequent one being hallucinations. So how many patients actually had to stop because of the side effect? 20% in GOCOVRI versus 8% in placebo. So still double-digit numbers, but that means that 80% were able to still continue the medication without having to stop it because of side effects. The most frequent cause for stopping were no dyskinesia, compared, for example, to the first two we discussed, hallucinations, and as you can see here, dry mouth, leg swelling, blurred vision, etc. So let's talk about hallucination for a second, because an interesting factor is it's age dependent. In a sense, patients above 65 years of age have a higher risk of hallucination, 31% versus 10% in the patient less than 65 years of age. Now, among those hallucinations, 62% were mild, 29% were moderate, and 10% were severe. Now, not everyone who had hallucination had to stop the drug. 38% of patients with hallucination had to stop the medication. But no one had to, so meaning 62% were able to continue, either because the hallucination resolved on their own, or because they were not bad enough and the benefit of the drug was substantial that the patient can still want to take the medication. And hallucination did not result in patients having to be admitted to the hospital or to be started on antipsychotics. In practice, how do we take GOCOVRI? It's 1 tablet of 437 milligrams at bedtime for a week, then 2 tablets of 137 milligrams at bedtime. Always at bedtime. If you skip your evening dose, please do not take it in the morning, because it will not work. It's engineered in a way where it's released slowly, 6 hours or 8 hours after you take it, and then it peaks when you wake up, and then it covers the day. So if you take it in the morning, it's going to peak when you're going to bed, and it's not going to help, and it can cause some insomnia. So always at bedtime. If you skip the dose, take it the next evening, not the next morning. If you're older, or if there's concern about hallucinations, definitely we can start at 68.5 for a week, then stay there or go to 137, and even go to 234 if we need to. But as a rule of thumb, when I feel a patient is a higher risk of hallucinations, I will start at 68.5 instead of 137. So this was what was new in Parkinson, in medication for Parkinson's disease. And now we're going to talk about what's coming soon. And we have like kind of 4 categories for that. Coming very soon, meaning the studies are out, but it's not FDA approved yet. Not that soon, but you can help, meaning we have research ongoing, and we would love you to participate if you're willing and interested. And looking for a new ticket, drugs that the first studies were not positive, but we think that it'd be to be studied again, because the study there was some flaw in the conception of the study. And the 4 that changed plans and canceled were unfortunately drugs that had negative studies, well-conceived negative studies, so they're not going to be pursued anymore. So let's look at the subcutaneous apomorphine infusion, used in Europe for decades with Britannia, and here in the US is with the company Supernos. It's submitted for FDA approval in February of 2020, still waiting to get the final rule from the FDA. basically, patients in the trials were given, it was a kind of a double dummy. You got a either I mean, not a double, you get an infusion or either of the drug or of the placebo, but you looked at two different targets. We looked at the of course at time, the amount of off time a day, how many hours off, but also the change in the pills, the amount of pills you were taking. So on the top left, you'll see the change in amount of off time a day. Green is the placebo, blue is the apomorphine pump, and the placebo decreased the off time by roughly 40 minutes, whereas the apomorphine pump decreased the off time by 2.5 hours. So it's quite significant. In terms of being able to decrease the burden of oral pills, you know, the carbidopa, the pramipexole, the everything else. In terms of levodopa equivalent, you'll see with the apomorphine a decrease of roughly 500 milligrams versus something like 100 to 150 milligrams of placebo. So 3 times more decrease in the oral pills. What about side effects? Well, because of the route of delivery being under the skin, it's under the skin, we had a bit of skin side effects with like nodules on the site of infusion, and affecting 77.8% of the patients. Dyskinesia, it is a medication to treat off time, so 38% had dyskinesia. Redness at the site of infusion, 27%. Nausea, as we said about KYNMOBI, it is apomorphine, and nausea is a potential side effect, 29%. Sleepiness, 25%. Dizziness, 20%. Headache, itching at the site of infusion, fatigue, bruising and pain at the site of infusion, and falls. So a few side effects on the site of infusion, in addition to dyskinesia and nausea. In terms of stopping the drug completely, 11% in the apomorphine pump versus 0% in the placebo group. In terms of side effects leading to decrease the dose, 48% in the apomorphine versus 11% in the placebo group. And they also have an open label study stretching over a year. And there is a, you'll see here, a sustained benefit of decrease off time by roughly 3 hours and increase on time without troublesome dyskinesia by roughly 3 hours. So benefit maintained at 1 year. So FDA, we're waiting for the FDA approval, but it's used in Europe for, I think, at least 20 years. Definitely will be a welcome addition to our toolbox. Now, the ropinirole patch, you know that you have ropinirole pills 3 times a day. You have ropinirole extended release pills once a day. And now the company has did some studies on the ropinirole patch, but has not yet submitted for the FDA for approval. So in a study of roughly 600 patients comparing the patch to the ropinirole extended release tablet or the placebo, so placebo, patch, and tablet. So basically everyone got a patch and a tablet. Either you got the sugar pill patch and the ropinirole tablet, or you got the ropinirole tablet and the patch, sorry, the ropinirole sugar pill and the working patch, or you got the ropinirole pill and the sugar pill patch, or you got both placebos, and they compared these together. And what they looked at was the change in the UPDRS-3, so the severity of the symptoms of Parkinson's disease between onset and 4 months later. And as you can see on those graphs, the upper graph of the clear squares is the placebo, and the 2 black lines are the patch and the pill for ropinirole. So they both did better than placebo, but there was not much difference between the patch and the pill. In looking at the change in off time, the placebo decreased by 0.81 hours, the pill by 1.74 hours, and the patch by 2.35 hours a day. Yet it didn't seem to be statistically significant. The difference between the pill and the patch was not significant. The patch also increased the on time without troublesome dyskinesia by roughly 45 minutes compared to placebo. In terms of side effects, I mean, in addition to what we typically expect or typically monitor, shouldn't say expect, with ropinirole, is, like the sleepiness, the hallucination, etc. Here, of course, is going to be some skin reaction because of the patch itself. However, you will see here that the last row, hallucinations were actually less frequent with the patch than with the tablet, 3.5 versus 6.6%. And hallucination is one of those side effects that we really monitor for those with this molecule. Another thing is also nausea. Kind of makes sense. It's by mouth. It's not by mouth. Was less frequent, 9% versus 15%. And of course, skin reaction were essentially seen with the patch rather than with the pill. So overall, the patch was as good as the pill for opinioral. It would be a welcome addition to having something else that is not by mouth. So far as in terms of patches, we only have the NeuPro patch or Accordion patch. So it's good to have yet another tool in available for someone around surgery or something like that, or doesn't want to take more pills. But we still have to wait for the company to apply for FDA approval. So these were the one coming soon. This is one not so soon, but you can help. So ongoing trials. Tavadapone is a D1 specific partial agonist. So ropinirole, for example, or pramipexole, which is Mirapax, or NeuPro, or D2, D3 agonists. And this one is a D1, so it acts on a different receptor. And we suspect, we hypothesize that it will cause less side effects, such as less dyskinesia, less sleepiness, and less impulse control disorder. The phase 2, the trials were completed and showed that tavadapone, either like you see here on the screen, as a monotherapy, so medication on its own in early Parkinson's disease, was beneficial compared to placebo, with 5 points less. So with a motor score that is 5 points lower compared to placebo, so 5 points improvement, as well as in terms of adjunct to carbidopa-levodopa, it increased by at least 1 hour in on time without troublesome dyskinesia, compared to well, it wasn't compared to placebo, it was compared to baseline, because phase 2 tried this were compared to baseline. So now we compare it to placebo, and we have those trials ongoing. And if you are interested, definitely let us know. So we have 3 trials going on: the tavadapone as monotherapy in early Parkinson's disease at a fixed determined dose, or as monotherapy in early Parkinson's disease, flexible dose, or as an add-on to carbidopa-levodopa in more advanced Parkinson's disease. And UT is actually a site for those studies, so feel free to reach out if you're interested. Other studies going on right now, actively going on: the pump patch NeuroDerm. Now, this is a pump patch of carbidopa-levodopa. So patch is a bit of a misnomer, because it's not a patch like the rotigotine or the NeuPro patch. It's actually a small subcutaneous pump, more like apomorphine, if you want, something in between there. And in initial studies, it showed, as you can see here, that you have quite constant concentration of levodopa and carbidopa in the plasma with that device, which you can imagine, we can postulate will give less dips, so less off time, and less peaks, so less dyskinesia. So right now we have the phase 3 are ongoing. It's called the Boundless study, where basically patients will receive this this pump patch versus placebo pump patch, and also have carbidopa or placebo carbidopa, looking, of course, at the change in off time and in on time without troublesome dyskinesia. The goal is to recruit roughly 400 patients. Unfortunately, we do not seem to have a site in Houston. If you're interested, you can go to Dallas or to New Orleans. We estimate that the study will be completed in July of 2022. However, remember, with COVID, we're having a lot of delays, so it might run later. So if you're interested, you can reach out to Dallas or New Orleans. This is the third categories. I have 3 minutes left, so I'm going to make sure to wrap it up, but we're going to be quick because it's negative studies. The Accordion Pill, where basically the idea, the engineering here is that it's going to release in the stomach for almost 12 hours, and hopefully then you can work with something twice a day. The phase 2 was quite promising. looking at different doses, as you can see here, where you saw a reduction in the off time by 44% with the accordion pill compared to the optimized current regimen. So roughly 2 hours in 2 different studies. On the left, it's a lower dose of 375. On the right, a higher dose of 500, thus a bit of a further difference. However, and the increase in on time with troublesome dyskinesia, with a lower dose, not much. With a higher dose, well, not much either, still stayed better than the optimized current treatment. So the purple is the current treatment, meaning the non-accordion pill. They had more dyskinesia with that one. So more sustained, so hopefully also less dyskinesia. Unfortunately, the phase 3 study, the Accordion study with 320 patients, did not show that, you know, this pill was superior to the carbidopa-levodopa pill. Okay. So patients were randomized taking, you know, one or the other, and unfortunately it was not better. However, after looking at the study again, they were like, I think we should have used a higher dose of the accordion pill, and so maybe we should try a new trial with higher dose. So right now, of course, you need money for that. So the manufacturer is looking for a partner to invest in that. So not yet, but maybe in the future. And the last part of my talk is those drugs that, unfortunately for us, did not make it to, you know, to prove themselves, you know, useful. Nilotinib. Now, nilotinib, if you remember, three years ago when I gave this talk, the same talk in 2018, nilotinib was very high because it is currently a, no, it still is a chemotherapy that you could get another way, and that one physician out of, you know, the East Coast, I think DC, said that, you know, it helps. He had a small study on 12 patients and it helps, and he was exploring it. And there was a lot of hype that, oh, it could slow the progression of the disease, and people wanted to try to buy it on the internet to give it to themselves. We could see this on blogs and social media. And at that time, I told you, please, please, please don't do that. There are trials going on right now, one by the same group that might or might not have conflict of interest, but one very seriously by the Parkinson study group and the Michael J. Fox, you know, Foundation. So neutral, the NILO-PD. And unfortunately, while nilotinib in the NILO-PD study was found to be safe and tolerated, was not dangerous as we were feared it would be, unfortunately, it didn't seem to help. It didn't go well enough into the brain. It didn't have the symptoms, and actually, although not statistically significant, there was a tendency to maybe make it worse. And so the expert opinion, impartial expert opinion of the people involved in the study was, we do not recommend it to test it further. I have not seen the results from the single center that might have conflict of interest. These were not published, at least I couldn't find them. So I'm going to have to say, please don't fall in the trap, don't take it. Inosin was a short PD3, also a molecule we were hoping would slow down the progression of the disease based on other, you know, studies before. Short PD3, we were a site, maybe a few of you were part of the study, and thank you if you were. Unfortunately, it wasn't better than placebo to slow the progression until the study was terminated early in March of 2019. And finally, azradipine, steady PD3, was also a molecule we were hoping would slow down the progression of the disease. We were also a slide. Some of you, again, were also involved in the study. And again, thank you very much for that. Unfortunately, the results were negative, and we cannot prescribe it as a drug slowing the progression because it doesn't. I'm just 1 minute over, and I'm not going to be put you late for lunch. I just want to thank you very much for listening, but also thank you very much for participating in studies. It's because of you that we have all those drugs, that we can help you and future patients with Parkinson's disease. If you don't participate in studies, we cannot know if the drug works or not. So again, thank you very much for participating in those studies.
All right. Thank you, Dr. Mehanna, for this presentation. I think people are always very excited to know that there's ongoing research and future treatment options out there ahead. I am going to hold people over just a little bit for lunch to go through just a couple of questions that I've kind of condensed or combined. The one is, I think there were several questions that came in related to disease modifying drugs, and where's research related to disease modifying drugs out there right now? Are there any going on? Are they looking promising?
So we always have a lot of studies for disease modifying. We even are studying infusion and things like that. But because, time limitation, I only wanted to look at anything phase 3, because phase 3 meaning we can hope to have something in the next 2 to 3 years once the study is complete and it gets approved by the FDA, versus phase 1 and 2, that, if it ever gets to the market, is going to be 8 or 9 years from now. And many of these don't deliver. At phase 1, it doesn't work, or it's too dangerous, or phase 2 or phase 3. So yes, we do have a lot of studies going on still, pills and IVs and others. So we're not giving up.
Okay, and since there are some new drugs that are out that are kind of in the same class as others, so Ongentys was one that we have that people had asked a question about, and how it's hard to get, isn't very widely prescribed. Is it okay to switch back and forth between different drugs within the same class, like Ongentys and entacapone?
I mean, of course, I don't know the whole picture since I'm not your treating physician there, so full disclosure. But I mean, yes, it happens. If you run out of Ongentys, you can go back to use entacapone. Just remember that entacapone, you'll have to take it with every dose of carbidopa-levodopa, not just once a day. And Ongentys, you have to take it once a day, not with every dose of carbidopa-levodopa. So as long as you don't mix up the frequency of administration, you should be fine.
Okay. All right. So those are the only questions that I kind of combined and condensed some questions that came in. And so we're not going to hold people over too much into lunch. I want to thank Dr. Mehanna for his time today and for going over this information. I think it's great to have these updates, and like I said, to know that there's more out ahead of us, and that there's still a lot of research going on. There's a lot of hope in research, and also, sounds like lots of good ways for folks to get involved if they're interested in participating in research out there. So there's clinicaltrials.gov that people can go to, and the Fox Foundation has a lot of good information on participating in clinical trials. So there's more resources out there if people are interested. So with that, I'm going to wrap up this session. Again, thank you, Dr. Mehanna. And for those of you who are joining us at home, this is a great time for you to take a little bit of a stretch break, move around. We will be restarting right at 1 o'clock Central Time to hear from Dr. Faraji on surgical treatments, and kind of the evolution of surgical treatments. So we look forward to having you all join us for that session and during this break. So thank you again, and thank you, Dr. Mehanna.
Thank you. Bye-bye.
All right, bye-bye.